Okay, we are going to start back with uterine cancer. I know I finished off with that, and I do want to talk about a few terms. So if you look on your book on page 66, I want you to look at the terms towards the middle and end. Metorrhagia. This is metorrhagia is uterine bleeding after menopause, basically. Then we have dysuria, which is painful urination, and then you have hysterectomy, which is a total removal of the ovaries, uterus, cervix, and fallopian tubes. So I just wanted to call those to your attention real fast. So let's go on to ovary on your PowerPoint, and we're looking at slide 66. A family history is the most important risk factor for ovarian cancer. Cancer of the ovary is influenced by hormones and reproductive factors, and the risk is greater among women with a prior history of breast cancer and no history of pregnancy. And ovarian cancer is very, very, very deadly. So that's something to be cautious of. Symptoms, if any, includes abdominal discomfort, bloating, abnormal vaginal bleeding, gastrointestinal abnormalities, and urinary tract abnormalities. Abdominal and vaginal ultrasounds can see if there's any tumors on the ovaries. The best method, of course, of testing for ovarian cancer is to do a biopsy. Surgery, for treatment-wise, surgery is usually our first option. Chemotherapy and radiation, but definitely want to remove surgery. But a lot of times when it's caught, it has metastasized already, so we have to be really careful. Their 5-year survival rate for any stage of ovarian cancer is 30% to 50%, so not too good. Let's look at figure 4.5. We're about to start talking about prostate cancer, but this shows you a digital rectal exam in the male where the prostate is, and the physician will use this most commonly to detect any kind of enlargement that could indicate prostatitis or some even prostate cancer. So it's really important for men to have this exam frequently, once yearly, especially when they get, above 50 to 60. So let's go on and talk about prostate cancer on page 67. This is the third most common cancer in men. In the United States, there's usually hundreds and hundreds of thousands new cases every year. Mortality increases with age. Usually we want to try to catch it early, and the way that we can catch it early is to do monthly testicular exams. Teach our men to do that when they come into the office or come anywhere. If you're the health professional, teach them how to do testicular exams, because the most common thing that they will find is a lump or an enlargement of the testicles. It usually gets more common when men reach 65 or older, and that's when we will start doing the PSAs, which is a prostate-specific antigen blood test, and that's when the digital rectal exams will happen as well. Of course, you may have some rectal exams before that as well as part of your yearly checkup. So, like I said, age is the leading risk factor. Dietary patterns suggest that high in saturated fat is another factor. Ingestion of some micronutrients have a protective effect against prostate cancer. So, symptoms of somebody that may have prostate cancer will be trouble urinating. You may not be able to urinate because the prostate has enlarged and maybe mashed down or compressed the urethra, causing urine not to flow. You may have urinary frequency. You may have some dribbling or a weak stream. You could have blood in the urine or pain in the lower abdomen. To diagnose, again, when men get a certain age, we do a PSA, which is a prostate-specific antigen, and this is a blood test to determine what kind of levels they are, and then we also what kind of levels, or if the person has an enlarged prostate or cancer. And then, of course, we do the digital rectal exam, but the most common way we diagnose is the biopsy. And again, for men, you want to definitely tell them to do a monthly testicular exam. Usually, if somebody is diagnosed with prostate cancer, I'm sorry, we're talking about prostate cancer, not testicular cancer, but they're both commonly linked, so I apologize about that. You can't really do a monthly exam for prostate cancer. I don't know where I was going with that. But anyway, when they're diagnosed with prostate cancer, they can get a CAT scan or MRI to determine what kind of stage the prostate cancer is in. Surgery, we have to remove the prostate, and that's usually recommended. Usually life expectancy is greater than 10 years. We want to do radiation and chemo on patients that aren't able to do surgery, or they're ineligible to do surgery. Let's see, if you look on figure 4.6, that shows you an early tumor and then a late tumor for testicular cancer. So now, I'm sorry I confused you, but let's go on testicular cancer is the one where men should do the monthly exams. So let's go at the bottom of page 67 and talk about testicular cancer. This accounts for 1.5% of all male cancers. Cancer of the testes can occur at all ages, but of course in men that are aging the third and fourth decades of life, that's when it's most common. So in your 30s and 40s is when testicular cancer may happen. Usually some common causes are environmental causes. Risk factors include a history of undescended testicles, which can happen when you're younger, and a family history, of course, of testicular cancer. And it's usually detected as a lump or a abnormal sizing testicular lump in the testicle, and that's usually how you notice it. And then sometimes it can be a little painful as well, but usually if it's painful, that just means that there may just be some type of cyst or infection going on, and it's not cancerous. So that is a good thing to remember. Therapy to treat testicular cancer: surgical resection, so we have to remove the lump, radiation therapy, and chemotherapy. So usually 80% will respond to all of these treatments, so that's a pretty good turnout. The most common malignant tumor of the testes originate from germ cells. So there's two types. We have the seminomas and non-seminomas. So seminomas is cancer of sperm-producing cells, and non-seminomas are cancers of embryonic cells. So seminomas are low-growing tumors, and they're sensitive for radiation therapy. Non-seminomas are not. So if we have any type, we preferably want to have the seminoma because it will respond well to treatment. Alright, let's go on and talk about some skin cancers. Actually, before we get to that, let's look at esophageal cancer. I'm not sure why your PowerPoint has this figure, but this is a malignant melanoma on slide 80, and this is a typical skin cancer. It's very deadly, but we will get to that later. If we don't get to that in this chapter, we'll definitely talk about it in the integumentary system. So let's go on and talk about esophageal cancer on page 68. This is the sixth most frequent cancer worldwide. Obviously, it's going to be more common in people that smoke, people that have chronic acid reflux disease, and people that drink. Symptoms are going to start with difficulty swallowing. You may have painful swallowing, pain with eating and drinking. You may have an unexplained weight loss, hoarseness, bleeding from the throat. So those can all be signs of esophageal cancer. Diagnosis. We're going to diagnose this, obviously biopsy is the most important, but we can do a microscopic examination of any kind of sputum as well for esophageal cancer, or we can do like a bronchoscopy to look down into the esophagus. We can have a CAT scan and an endoscopic ultrasonography, which is where they just run the tube down the esophagus to look around. And that will determine the extent and how far and if it's spread. The treatment for this is removal of the esophagus, surgical removal of the esophagus, radiation therapy, as well as multiple chemotherapy regimens have been used alone, or it may be combined with surgery. So these approaches are rarely curative, so not a good turnout if you have esophageal cancer. The overall 5-year survival rate is about 10 to 20%, so not very high whatsoever. Going on to bladder cancer on page 68. This is the 9th most common cancer death worldwide. The most common factor is cigarette smoking, and this about 65% of patients that have bladder cancer are smokers, and then 65% are males, 30% are females. Risk factors for this: exposure to certain industrial chemicals like asbestos, things of that nature is a risk. Worm infestations can cause that. We have schistosoma, hematobium, I can never say that word. This is linked up to a 5-fold risk of bladder cancer if this kind of worm infection happens. The most common symptom of bladder cancer is hematuria, which is blood in the urine. We can have surgery alone, or it can be in combination with some type of radiation or chemotherapy. And those usually have to be done in 90% of the cases. The 5-year survival rate is 82%, so pretty good survival rate for bladder cancer. Going on to head and neck cancer. This is the 11th most common cancer worldwide. Twice as high in men than in women. Again, risk factors: smoking, alcohol intake are the major risk factors for these. Symptoms of this: you're going to have, especially in the mouth too, this is going to include head and neck cancers, oral, which is within the mouth. But oral cancer, of course, you can have sores, bleeding, difficulty in opening the mouth, difficulty in chewing and swallowing. You may have a pain in the lymph nodes of the neck, or you may have speech issues. There's not really anything that we can do to screen for this test. Usually these are detected by dentists. You may go in and say you have a sore in your mouth that won't heal, and the dentist will take a look at it, maybe do a biopsy, and determine that you have some type of oral cancer. The treatment for this is a tumor resection, so we're going to try to remove the tumor and preserve the tissue if we can. We usually have to do radiation or chemo. Let's see, we usually have to use radiation and then chemo if it's more advanced. So let's go on and look at lymphoma on the top of page 69. This is a neoplasm of the lymphoid tissue, and we can either have Hodgkin's disease or non-Hodgkin's lymphoma. So those are the two types that we're going to talk about, starting with Hodgkin's disease. This is a malignant lymphoma, so it is cancerous. And it's distinguished from non-Hodgkin's lymphoma by a particular type of cell. So Hodgkin's disease has a large cell called the Reed-Sternberg cell, whereas non-Hodgkin's does not have that, okay? Hodgkin's disease usually will happen in young adults. The risk is going to be elevated with certain infections like HIV, wood or wood product exposure. So these type of infections will increase your risk for getting Hodgkin's disease. Symptoms: you're going to have just a swelling of the lymph nodes in the neck. You can have it in the armpit or the groin. Anywhere there's lymph nodes, you may have like a little swelling of the lymph node, and it's usually painless. It may cause a little discomfort, but usually not too painful. To treat Hodgkin's disease, we're going to treat that with chemo and combinations of different agents of chemo. Survival is related to the extent of disease and how fast we diagnosed it. The 5-year survival rate is between 70 and 90%, so pretty good. Now, going on to non-Hodgkin's lymphoma, patients with HIV and AIDS are going to be the type of person that will get this. Even people that may have lupus or other autoimmune type diseases, they're going to be the ones that are going to get non-Hodgkin's lymphoma. Viral infections, if they've had any type of viral infections, that can also put them at risk too. The most common symptom of non-Hodgkin's lymphoma is a painless swelling of the lymph nodes, just the same as Hodgkin's disease. To diagnose this, we have to do a microscopic evaluation of the lymphoid tissue. So we're going to have to do a biopsy. We can do an X-ray, CAT scan, MRI. We can do a bone marrow sampling, and a lymphogram. So that's all of those can tell us how fast the disease has spread, if it has, and what stage it's in. Treatment for non-Hodgkin's lymphoma is radiation and or chemotherapy, and it's going to last several years to get rid of it. The goal is to treat advanced low-grade lymphomas and to cure it. So we have to do quite a bit of chemotherapy and radiation combined. And then we can also do bone marrow transplants. That's a fairly new thing that we can do. So let's go on to leukemia on page 70. I know I'm kind of going through fast, but I don't want to take too much time on all of these different types of cancers. So leukemia is a cancer of the white blood cells. It's production of a large number of abnormal leukocytes, basically. This can happen in autoimmunity diseases, and it can happen in children as well. So this is an overproduction of malignant white blood cells, and it suppresses the production of red blood cells because of that, and platelets as well. The liver and spleen are going to be affected with this, and they can start getting enlarged, and cancer can spread to those organs through the white blood cells. The cause of leukemia is unknown. It could be due to a virus, or it could be due to exposure to radiation. So we really don't know the cause of it. It has been reported in areas around the world where they've had been exposed to it, like a fallout of nuclear energy, basically like a leaking of nuclear energy, and scientists think that heredity has a play in it as well. Signs and symptoms of leukemia. We're going to have fever, swollen lymph nodes are the most common thing, lymphadenopathy. We're going to have joint pain, abnormal bleeding, weight loss. We may have trouble eating and drinking. Shortness of breath, heart palpitations. So there's quite a few symptoms of leukemia. Blood clotting is reduced with a reduction of platelets, causing a tendency to bruise and hemorrhage, and you may become a hemophiliac as a result of this. White blood cells are produced faster than they mature, and then what is happening is the leukemia is invading the white blood cells. Let me close this door. Sorry about that. So what I was saying was white blood cells are proliferating a lot faster, and they're immature. They're not maturing, and the leukemia will attack it, and that's what causes the inability to fight infections and causes leukemia to have a very hard cure. The types of leukemia, we have myeloid leukemia. This originates in the bone marrow. So treatment for this is going to be bone marrow transplants. And then we have lymphocytic or lymphoid leukemia, and this is the malignancy of the lymphatic cells found in the bone marrow and lymph nodes. So again, we can have a bone marrow transplant for this, or removal of lymph nodes as well. Let's see. If we have acute lymphocytic leukemia, this is the most common form that we may see in children. This usually starts very abruptly and progresses very rapidly. And so this is why children, you'll see when they have leukemia, they have a very short lifespan because it just goes through their body so fast. Chronic forms of leukemia are more common in adults, so the lifespan may be a little longer, but it is still deadly. They produce cells that undergo some maturation and can function partially. And then children, of course, theirs cannot function. So with the chronic form of leukemia, it's going to progress a lot more slow. Treatment depends on the stage it's in. We want to try to eliminate the leukocytic cells or leukemic cells, which are infected with a leukemia. So we want to try to inhibit their growth, maintain remission if we do go in remission, and prevent complications. Side effects of chemotherapy are very bad. The ability of the patient to tolerate adverse medication effects determines the intensity of the chemotherapy. So the physician may have to start lower and work his or her way up to see how well the patient can tolerate it, because the side effects are pretty bad. Now let's go on to pancreatic cancer on page 70. This is the 14th most common cancer worldwide and the most deadly cancer worldwide. It's often diagnosed in the last stages because usually it's asymptomatic until the patient starts having weight loss. They may have some jaundice, which is yellowing of the eyes and skin, diarrhea, weakness, abdominal pain. So to diagnose it, of course, we're going to do a biopsy, but we can also do an ultrasound to see if the pancreas is enlarged or anything like that, or we can do a CAT scan to look at the head and tail of the pancreas. And then we can see if it's involved in any surrounding tissues, which by the time you have symptoms, it usually has. Surgery offers the patients the only chance for a cure, but of course you have to be on a waiting list, and sometimes you may not make it to the waiting list. So we mainly have to treat the symptoms. We may do treatment of jaundice, gastric obstructions that may happen because of it. And then we may do some chemotherapy to try to prolong the life while you are on that waiting list to get a pancreas. Survival rate is very poor, and they usually die within 1 year of the diagnosis of pancreatic cancer. Alright, so now let's go on to melanoma. That picture was just kind of thrown in there at an incorrect time. Melanoma is a skin cancer, and it's malignant proliferation of pigment-producing cells, or melanocytes. And this is a very, very, very deadly form of skin cancer. So the risk factors for melanoma are going to be light and fair skin, sensitivity to sunlight, sunbathing, like prolonged exposure to industrial chemicals like tar, arsenic, radium, and then any kind of past history of skin cancer will definitely increase your chances of melanoma. These can occur anywhere on the skin, but in men it will usually appear on the back, and in women it usually appears on the legs. So we have to be very careful. And sometimes a mole that you've had all your life, you have to really watch those, because those will usually turn cancerous into melanoma. So we really have to watch those. Early detection of skin cancer is possible by having your skin examined once a year. They usually starts with a small mole, and then it will start changing colors. The margins will start getting off and not even. And so we just kind of have to look at the asymmetry and the border and the color and diameter of the lesion to determine if it's a melanoma. And of course we can do usually what's called a skin punch biopsy, where it just comes in and takes out the middle portion of the skin cancer. Surgery, the treatment is surgery to remove it. We usually have to do radiation because it's usually metastasized to other organs in the body, and so sometimes by the time it's already, the melanoma has changed color, or the mole has changed color, and you realize it's a melanoma, it may have already spread. It's very, very fast spreading. So we go by A, B, C, D to detect melanoma. A is for asymmetry, B is for border, C is for color, and D is for diameter. That's what they look at. And then you have a slide in your PowerPoint where you can look at a video on the topic of skin cancer. Alright, going on to thyroid cancer and then kidney cancer, and then we'll talk very shortly about the rest of the chapter. Thyroid cancer, very rare, but it can happen. This is usually due to an iodine deficiency. You may have had a radioactive iodine exposure or any kind of radiation exposure can cause thyroid cancer. The thyroid cancer does grow very slowly, and it's usually cured by complete removal of the thyroid gland. So chances of death are very, very low. It usually causes no symptoms. You may get what's called a goiter, and that can be a symptom of thyroid cancer. But some symptoms of it is a hoarseness, dyspepsia, which is painful digestion or painful eating, dysphagia, not being painful, drinking and eating. You may have some shortness of breath. So again, the only way to diagnose this is with a biopsy. The most common kind, we're going to go on to kidney cancer now, the bottom of page 71. The most common kind of kidney cancer is renal carcinoma. And renal carcinoma is going to be more common in men than in women. Kidney cancer, just like bladder cancer, the most common people to have this is your cigarette smokers. Obesity can also be linked to this, especially in women. Leather tanners, meaning women and men, but mainly as women, we like to tan. We lay in a tanning bed all day, we sunbathe, and our skin gets leathery. Shoe workers, dry cleaning employees, and people that have been exposed to asbestos. Kidney cancer usually causes no symptoms in its early stages, but then as it advances, we can have the blood in the urine, we can have flank pain, which flank is right here on the sides. That's what your flank is. And we may even have a palpable kidney mass that you can feel, the kidneys, it would be in the back. You may have like a little bulge on each side of your spine back there. So things that we can do to detect kidney cancer, we can do a urine test to see if any of the like ketones or anything like that are kind of out of whack, and to see if there's blood in the urine, and that will kind of give us a clue. What we can do as well is an IVP. This is an intravenous pyelogram, and it's an x-ray where they do a dye and it goes through the kidneys to see how they filter, and it'll show you if there's any tumors or anything like that. Surgery is the most common treatment for kidney cancer, but of course you have to wait for a transplant. Usually family, if it's the same type of tissue and the same type of blood type, family can give a kidney. Sometimes it works and sometimes it doesn't. It just depends. Renal cell carcinoma, if you do have that type, that is very treatable. It responds to treatment very well. Alright, cancers of the nervous system on page 72. The majority of these are come in adults, and they occur in the central nervous system. These cancers are very rare, but actually they're getting more and more common in children, and we think that maybe it's related to prolonged exposure to TV or headphones, earbuds in the ears, listening to music. That's just a educated guess. Nobody really knows. So it has two peaks, one in childhood, like I just told you, and then older adults between 60 and 70. And then, of course, the brain is the most common place for metastasis for other cancers. Let's see. Sometimes in children, especially if they've had some other type of cancer and they're using radiation for treatment, sometimes the radiation can cause a brain tumor to develop. So that's a possibility. Signs and symptoms. Paresis, and I want you to look at that. That's one of your key terms. This is a slight paralysis. Speech, you may have some speech disturbances, some personality changes. So there's, and then you, of course, you can have seizures as well. So there's a lot of symptoms with this. Large tumors can be life-threatening because it puts too much pressure and causes a massive brain damage with that. Headaches are very common in this because of the increased pressure in the cranium. To diagnose, we can do a CAT scan, we can do an EEG to diagnose as well. Of course, brain biopsy will provide a definitive diagnosis. And then what we do for treatment is surgically remove the tumor with either a craniotomy or laser surgery. Dexamethasone, this is a medication that we use for this, and it helps reduce the size of the tumor. Doesn't help it really go away, but it will reduce the size, and it reduces the swelling around the brain, which can help with the headaches and help with seizures and things of that nature. Let's see. And then pediatric cancers is the very last topic here. This is the second leading cause of death in children is pediatric cancers. So these happen too frequently. Symptoms of early cancer in children are usually mistaken by things like the flu, ear infections, colds, tummy aches, things like that. So we include loss of energy, pallor, which is paleness, bruising easily, persistent pain, prolonged fever can be associated with it, frequent headaches, profuse vomiting, sudden changes in vision, sudden changes in weight loss. So you have to really pay attention, because if it's a prolonged tummy ache or prolonged cold symptoms, prolonged fatigue, it could be a pediatric cancer. So you need to make sure you keep an eye on that. Treatment for these are treated with surgery, combination of chemo and radiation, and unfortunately, well, you know, the survival rate has improved. It was not good at all, and it's still kind of low, but it is improving day by day. Children may get secondary infections or secondary illnesses because of cancer treatment, and it's usually the side effects are just horrible for them. So if you look at table 4-5, you do not have to know the percentages of cancer, but this kind of talks about childhood cancer, the different types. I do want you to look over these and look over the disease descriptions, okay, because they will be on your test. Let's look into cancer and aging on page 74. You know, as we age, everything, I think we talked about this in the very first chapter, but as we age, everything decreases and everything stops working as well, and that's why cancers become so prevalent in age. Cancer treatment for people that are 50 and above, or maybe a little bit older, are usually the same. Some patients may choose not to be as aggressive just because they are older, and then some patients do want the same aggressive treatment. It totally depends on the patient. So just to recap here, the screenings for cancer, or diagnosis of cancer, some of the screening recommendations are MRIs, endoscopies, ultrasound, biopsies, pap smears for your female cancers. So those are just a synopsis of that. And then the cancer staging, we have what's called the T&M system. And you can look at that. I'm trying to see where that is. I don't know where that is in your book, but it is in the PowerPoint, and you do need to know it. The T&M system is how they stage cancer. The T stands for the primary tumor. The N is the number of lymph nodes involved, if any. And then the M is any metastasis, where it has spread. And we have 4 stages, 1, 2, 3, and 4. 1 being the early stage, 4 being the last stage, and that usually ends in death. let's see, cancer treatment. We have just trying to prevent cancer in general. Chemo prevention, we try to use other things besides chemo. Screenings, chemotherapy, radiation therapy, surgery. Those are all different types of things that we look at. And then table 4.6, this shows you the most common cancers and the screenings that are associated with it that you should follow, okay? Because this can help you avoid cancers. Non-specific warning signs of cancer in box 4.1. Make sure you look over those really well. Let's see, I'm seeing if there's anything else we need to look at. And I think that's it. You can look over the diseases at a glance from 76 through 83. It gives you a good synopsis of all the diseases that we talked about in this chapter. Okay, so that's the end of chapter 4.